Been a bit of time since the last episode of Get Reporting with Me. I'm Dr. Matthew Leonardi. We're going to be jumping into a case of endometriosis as March is upon us, and it is Endometriosis Awareness Month. Before delving into the series of pictures and videos, I'll tell you a little bit about our patient. We have a woman in her mid-20s who has described chronic pelvic pain, chronic dysmenorrhea with every cycle, having pain with intercourse as well. Periods are quite regular at around every 30 days. Here we have image number 1. Whenever I start a scan, I take the first image of the probe right at the beginning, right before it goes in, essentially, as sort of a timestamp in some ways, but also as evidence that we have started our transvaginal ultrasound. Here we have another image coming in, not really a whole lot of great value from assessment of structures for endometriosis, but I will point out that you can see the retroperitoneal rectum in this particular clip here. Right there, this is our vagina splaying anterior and posterior. As we come in a little bit further, here's our retroperitoneal rectum as well. This is the lumen. Here's mucosa, anterior and posterior, and this is the anterior wall of the muscularis layer. Just on this side of it, we have the rectovaginal septum, so it's going to be this region here, and this is their vagina that's still splaying as we're pushing the probe in. Our urethra is going to be in this region right about here. So the probe is now in, and we have a couple things that we're seeing on this very first picture. This is our already noted retroverted uterus. We're noting some fluid within the rectouterine pouch, and we're now seeing here our upper rectum, which is our intraperitoneal rectum, that's above the rectovaginal septum. This here would be considered the posterior compartment on the right where the mouse is going over, and our anterior compartment would be everything to the left of the uterus in this retroverted uterus case. A couple other things to point out that might not be so instantly recognizable for people is the vagina. Okay, so when the probe is in, you literally have to think the probe is touching the vagina. Therefore, the vagina is the closest layer to me. And that hypoechoic line right on the other side of the probe is the vagina. And on the other side of that hypoechoic line is the peritoneum. This is the peritoneum of the rectouterine pouch. And this is overlying the back of the vagina. And it is in continuity with the back of the uterus. So this will eventually come back to the retrocervix area, and it will start to blend into the posterior uterine serosa as I'm coming up there. This should be a potential space, and we'll see that in a little bit. This will also, in its lateral position, start to blend with the uterosacral ligaments. And inferiorly, that pouch peritoneum, rectouterine pouch peritoneum, ultimately comes to the base of the rectovaginal septum there, at the base of the pouch, and you get the peritoneum overlying the rectum. So the beginning of every endometriosis ultrasound I do is looking at the bowel. I follow the bowel from the anal verge as high up in the body as I possibly can. And when I do the scan myself, this is a scan that I've actually performed myself. I'm in real time interpreting the things that I'm seeing or not seeing. And so I do my best to capture good pictures, but sometimes I'm not very comprehensive in capturing every segment. But if you're trying to show pictures to another person, you should try and capture as much as possible. So we have here that retroperitoneal rectum, rectovaginal septum, vagina. This here is the very base of the rectouterine pouch. There's that fluid again. And in this particular area, you can sort of see probably where that bowel fold is going. And this is exactly where it enters the pelvis. It becomes intraperitoneal. This is our anterior muscularis layer here, and this is our posterior muscularis, which is generally unaffected by endometriosis. We also have a little segment of bowel over here on the left that we're seeing, but we need to connect those dots between here and here. So let's see what's coming. All right, here we go. So we have a cine. And as I always teach with a cine, you can pause and scan through it nicely. So that's a good segment there. We're seeing this is where this fold is coming in here. It comes up here. We're seeing a very overall similar thickness of that muscularis layer all throughout. Comes down here and then around. And then we're starting to see it even on this area here on the left side of the screen. And this is actually coming on the anterior side of the uterus because this uterus is retroverted. And actually with a retroverted uterus, sometimes not a lot of the bowel is sitting in the pouch because the fundus of the uterus essentially holds it out of the pelvis. It kind of closes the space a little bit. So you can see in this pretty quick clip here that uterus is retro and it's pushing down right at this level on the rectum. And the most of the large bowel is actually staying outside of the pouch. And there we have a nice segment of it coming along here. Up, up, up. When I see that it's coming above that level of the uterus into the anterior compartment, I'm starting to get really less worried about there being an isolated bowel nodule, as bowel endometriosis is most often in the rectum at around 8 to 12 centimeters from the anal verge. And at this point, we're actually quite high. We're probably at the level of the rectosigmoid junction at around 15 centimeters. And so way less likely for there to be an isolated lesion here. Let's come through this clip again, because there's another thing that I want to point out that would have caught my eye as I was doing the scan, but I teach the principle, stay focused. Don't get distracted by something and move on to it until you've finished a task. And the bowel is a really important task to finish before moving on. But in this clip, we obviously have an ovary. There's a nice dominant follicle there with a number of peripheral follicles there. That's our ovary. And that's going to be, it's the left ovary in this case. But just look at this area right here, okay? So this caught my eye pretty instantaneously. Again, think about proximity to the probe. There's our probe. This is really close to our probe. We're going to put a little measurement on it. We're talking about something that is less than 5 millimeters away from the probe. And that already, in the first few seconds of this scan, has given me the diagnosis of endometriosis. This patient has left uterosacral ligament endometriosis. As we scan through that, you can see this hypoechoic area. There are a few little hyperechoic foci as well within that area there. But I didn't get distracted. I stayed on the bowel, finished the bowel before moving on. So let's see what I moved on to next. All right, I moved on to some other really important standard things that need to happen during a scan. You need to assess the uterus and the ovaries. You need to follow a standardized approach. So that's usually my approach. Bowel, kind of have a little glimpse of what's going on, and then capture a lot of my standard things. So our retroverted uterus is normal in size, it's normal in length, and its anterior-posterior diameter. It's normal in its width, normal in volume. Then we move on to the endometrium. And you should already have suspected that the endometrium would be on the thicker side because you saw the dominant follicle already in that first cine loop of the posterior compartment. So we have an endometrium that's about 10 millimeters. And then I identified this area in the lower segment that seemed to be giving me polyp vibes. And so this is a pretty small polyp, 6 by 4 by 6. You can appreciate that there is a bit of a hypoechoic area just here, and it is mostly enhanced by the fact that there's a hypoechoic area just around it in that area as well. So let's have a look at the clip. One of the interesting things is that around that mid-cycle time, because of an attempt, a goal of the uterus to move sperm to egg, there is myometrial contractility. And you can use that to your advantage because something within the cavity might actually move. And that you are seeing very, very clearly right here. You see this polyp is actually moving with the surrounding endometrium due to the myometrial contractility. What we're also seeing, or not seeing in this case, in this clip, is that I can't really identify a feeding vessel to the polyp. It's very small, the polyp, so it's not surprising that we're not seeing the vessel, because it's probably a very, very small vessel with very slow flow. So there's that polyp in motion, and this is a still image of the vascular pattern or lack thereof over the polyp. I think I was pretty excited to see the polyp moving. And so here's another little clip. You can see this area just here. This is with the color off. It's definitely less subtle, rather more subtle than the previous clip, which is a really strong myometrial contraction. But you can see there's that border there. So I'm pretty convinced about the polyp. As you may have learned from previous videos, I'm happy to recommend sonohysterography when I really feel like we have an equivocal result or I'm not quite sure. In this case, I'm quite sure that there is a polyp here. Moving on to the ovaries. And so we have a right ovary here. You can see right. And upon first glimpse, I'm already concerned about polycystic ovarian morphology. As per the 2023 guidelines, a single image of an ovary with more than 10 follicles present gives you the classification polycystic ovarian morphology, PCOM. And you can see in this side here, maybe even in this side, but let's focus on the right, that we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 follicles present. So that already meets our criteria. But you know me, I'm not a still image person favoring still images. So of course, let's do a cine loop of that ovary. And I'm not going to bore you with a count, but if you spend time, you pause my video and go through that ovary, you'll capture more than 20 follicles, none of which are over 9 millimeters here. So this is a polycystic ovarian morphology. And let's just pause this for a second, because out in the periphery, I also got another little nice glimpse of that polyp right there in this area here. And sometimes it's interesting because you see something better when you're actually not trying to capture it. In this case, I'm focusing on the ovary, and that polyp is showing a bit more difference in the echogenicity to the surrounding area. We also have a lot more bowel in this clip here, but we've already assessed that. So cines are really useful because if after the fact you want to come back to something, you have a lot more information in that clip than you might think you've captured. I think I took another clip of it just for comprehensive sake. And then I moved on to the left ovary. And so in this clip, not only are we capturing the ovary, but we're also capturing the uterosacral ligament, endo, and we're capturing a bit of the uterus. And there's some fluid there in the pouch. So we have a dominant follicle here. And this other side also did have more than 20 follicles, if you count. I believe that it is really important to count in almost every patient. If it is very clearly subjectively abnormal with 30, 40, 50 follicles, maybe you don't need to count. If it is clearly very subjectively less than like 1, 2, 3, 4, 5 follicles, then don't count. Anything in between, I think you should count, because you'll be surprised. I think that the report of polycystic ovarian morphology is under at this point in time, because most people are not routinely collecting cine loops, and most people are not routinely counting in every single patient. Here's our measure of the ovary. Our volume is normal. Color flow. All right, so moving on now to a more focused posterior compartment assessment. And one of the newest things that we've published on and we've introduced because it's very easy, and I believe that because it is so easy, the ability for us to say whether something is normal or abnormal is actually also very easy. This is the triangle sign. And so what you can see I'm doing here is I'm applying pressure to the retroverted uterus, to the fundus of the uterus with the transvaginal probe. I'm applying pressure, and then I'm releasing pressure. And as I release pressure, the fluid in the pouch here fills the space in a triangle shape. Okay, so that's a positive triangle sign, indicating a non-obliterated rectouterine pouch. What's also sort of happening in this clip, though not as clear, just a little bit at that point, is there is slide between the fundus of the uterus over here and the bowel, just at that part right around here. We're seeing that slide happening. When you see this amount of fluid here, almost covering the entire posterior aspect of the uterus, the pouch is non-obliterated, really. You can have partial obliteration in some cases, and so you really do want to check laterally as well, especially when you have uterosacral ligament endo. So you want to check in that area, but this uterus is definitely falling off the back of the vagina really nicely, as well as sliding along the bowel. So we have a positive sliding sign at the level of the fundus and the bowel, and we have a positive triangle sign between the posterior uterine serosa and the peritoneum overlying the back of the vagina, the rectouterine pouch peritoneum. I'll pause this because there are a couple other interesting small things that are just popping up along the fundus of the uterus that look like superficial endo. So right here, it's not so nicely depicted in this frozen aspect of the clip, but if you just watch this over and over again, you'll see that there's something at that area that's hanging on the uterus. And there is a common location of superficial endometriosis along the posterior aspect of the uterus and onto the fundus. And so that is one area that endo can affect. Even though we say endometriosis is an extrauterine disease, it's outside of the uterus, it can be on the surface of the uterus. Is there anything else in this clip? Is there any other superficial endo? Not a whole lot else jumping out at me, so I'll move on to the next clip. And so here we have a nice depiction of a normal uterosacral ligament. And so in this case, this is going to be our right side because we already know where our abnormal side is. And you see the nice white band. We see that it fans out as it reaches the sacral aspect. And in the retroverted uteruses, uterosacral ligaments can be a little bit harder sometimes to appreciate. They can be much more long and stretched along that posterior vagina, as the posterior vaginal fornix is larger in a retroverted uterus. But this is a really nice classic depiction of that. And then just coming a bit more medially here, we're seeing more uterus. You see very, very little uterus here, starting to see some of the lateral vessels, a little bit more uterus. We still have a little tiny bit of thickness, less than here, but it's starting to thin out. And then I'm coming central, and I've frozen on this one for sure, because check this out right here. This area right here is superficial endometriosis on the rectouterine pouch peritoneum. You have a very clear evidence of a hyperechoic focus. Moving on to the left uterosacral ligament. So we have that ovary very close there. And here's the measurement of the left uterosacral ligament. Just again, think a little bit about how small some of these things are that we can see and what we used to believe that we could or couldn't see. We're seeing really small deposits of endometriosis here. And if you look at this depiction in this sagittal plane here, this is our depth of penetration of width here. We're measuring that as the W, 2.5. This is small, very small in terms of its infiltration. Historically, this would have been called superficial endometriosis because it didn't penetrate more than 5 millimeters of depth. But now any depth of penetration, any infiltration beyond the surface of the peritoneum is considered deep endometriosis. So this is a deep endometriosis nodule. There's another depiction of it without the calipers overlying it. Here it is right there. Lots of pictures of that nodule just there, just here. It is possible that at some point in time, this ovary could become adherent to this because this is inflammatory. Right now, this ovary is mobile. I don't think I've captured a very good video of that. Maybe it's coming, I'm not sure. But right now, it's not stuck there. Most ovarian endometriomas are actually born at the site of an adhesion to endometriosis on the peritoneum, often the uterosacral ligament. So I would be worried in this case that if and when this ovulates, which it looks like it's imminently going to do, the repair cycle of that follicle rupture could happen at this area right here, in which case you may have active endometriosis at the healing site, causing development of endometriosis within the ovary in a process called invagination. And that is most likely the source of most endometriomas, is the invagination process. So I've gone back to center here. I think I'm showing that hyperchoic area just there again. And yeah, here it is. And I don't usually measure superficial endometriosis, but I obviously educate a lot of people on endometriosis, and I educate patients on endometriosis as well. So in this case, I put the calipers on, and you can see it's 0.5 millimeters. So even way, way, way smaller, almost 10-fold smaller than the deep endometriosis nodule that we've seen today. This is tiny. And so I turn the screen to the patient and I say, look, this is what is in your pelvis. This might be one deposit of several superficial areas. I can't always see all of them. And at this point in time, I still can't rule out superficial endometriosis when I don't see it. But I do like to show people what is possible. And 0.5 millimeters is pretty impressive that we can see this. There on the back of the uterus is that area again that I raised earlier. That's a better depiction of it. Still a bit of motion artifact in this image, but not too bad. Not sure why I captured this, maybe because the polyp showed itself really nicely again. Other than that, I can't really see a whole lot in this picture. You can see the bowel and the periphery kind of coming around and then capturing it again there. And then I move on to the anterior compartment to complete the assessment. So essentially, when the posterior compartment is as normal as it is here, I mean, it's abnormal, but it's not tremendously abnormal with large nodules and obliteration and ovarian fixation. But when it's in this state of milder disease, I have a less of a concern for the anterior compartment level of disease, mostly less concern for the ureters being impacted directly by endometriosis. But I still look at them every time. And so here we have a central view of our bladder. And by doing the bladder at the end of the scan, you usually have a bit more urine in the bladder, which allows you to release and then capture the entirety of the bladder mucosa and muscularis. I don't think I have a clip of that. And then moving on to the ureters, I can't quite tell you which side this is because I'm not always so good at annotations. I should be, but when things are abnormal, when we're talking about the ureters, definitely there's annotations and measurements. And so we can see this is the path of the ureter right here. This is exactly where it crosses the uterine artery. And when I'm really concerned, I follow it way beyond the level of the crossing, because this is usually where perimetrial endometriosis occurs, at that exact level. And so I'll follow this up along the pelvic sidewall. And here we have the other side coming there. And this is where it'll cross. It'll turn around at that point. This is the uterine here, and this will be where it crosses and comes down the pelvic sidewall. There's another picture of it there, but not overly concerned about the ureters in this case. So I think this is the end of the scan. I will just come back to this particular picture as I tidy up the final message here. So essentially, we have a person in their 20s who has had long-standing period pain from day one, and that pain has transitioned into more of a chronic or persistent pelvic pain, yielding other newer symptoms like pain with intercourse, dyspareunia. Dyspareunia can actually be very directly related to uterosacral ligament endometriosis deposits, as anything that's inserted into the vagina, obviously most commonly a penis, but it could be also other things like sex toys or vaginal wands, for example. This area can elicit pain. The other source of pain is not the nodules specifically, but it is the pelvic floor muscles that become overly sensitive when endometriosis exerts its inflammation on them long term. And so we have to try and identify whether pain is coming from the nodule or whether it's coming from the pelvic floor muscles, or is it coming from both? And that has a lot of impact on how you counsel the patient and how you want to treat them in the future. Surgical excision of uterosacral ligament nodules can be very good if the pain is very focal in that particular area. But if the pain is more diffuse, more muscle specific, then taking that endometriosis out is not going to fix the muscle problem. It may fix other problems. And so the patient should and would be recommended to be working with a pelvic floor physiotherapist to address the muscle-related issues. Uterosacral ligament endometriosis is the most common site of endometriosis in the left, is more common than the right. Our team will be publishing a study soon that shows this. This is something that's already known in the literature in terms of the disease distribution. So that is an important point, because the uterosacral ligaments, if they're the most common site, should be routinely assessed in all patients. And they can be a bit more challenging, but there's a lot of resources online, including on my YouTube channel, that you can learn more about the uterosacral ligaments. So for now, that's all. And I look forward to seeing you on the next episode of GRWM. Take care.